Yes, so today's topic is on feeding techniques in hospitals. So feeding techniques, which by the term is very, very simple. So this term I requested Madam Meera because when internship students come to us, basically the area which they lack is enteral nutrition and parental nutrition, because in colleges, in books, textbooks, we don't go into such details. Only in a hospital setup do we get an opportunity to read about this. So that is the reason I thought I should educate the budding nutritionist about how a patient is being fed in a hospital and why should that patient be fed when he or she is admitted in the hospital. For that, we should know what malnutrition is. So malnutrition, all of you know, comes from extended inadequate intake of nutrients or severe illness burden on the body composition and function. It affects all systems of the body. So malnutrition is due to inadequate intake of nutrition, which occurs due to severe illness inside the body, and because of this, the body composition and functions are altered, and therefore the patient, an individual becomes malnourished. So, but the truth remains this. So, but the truth is, hospital malnutrition has been there from 1974, and it's more than 40 years now, and still all of us are addressing about hospital malnutrition. So, but that is the bitter truth, and still we are battling malnutrition in a hospital. So, because malnutrition is not included in a well-known comorbidity tool as yet. So we say patients, we look at the patients who are diabetic, we take care of the patients who have renal functions, we take care of the patients who are cardiac patients. But so far, malnutrition has not been included as a comorbid tool. Only when that importance is given, I think malnutrition can be eradicated from hospitals. But the good news is, abroad, all the hospitals have have brought in, especially the insurance companies abroad, have brought in a protocol that a nutritionist has to sign off that the patient, or when I say sign off, give a clearance for the patient to be taken for surgery. So that means even malnutrition is coming up as a tool for comorbidity. So now, what are the types of malnutrition? This is a simple term because all of you will understand these terms. That's why I put it here. So all of you would have come across the term of marasmus. Marasmus is nothing but protein, calorie, malnutrition. Here, the one thing you should understand this, these patients' oral intake is acceptable. That is, they have a protein-calorie ratio of a normal ratio. But when you go into details, you find that there is an inadequate intake of intake in terms of quantity of the calories. So these patients, when you do an assessment, physical assessment, you feel you can find out that they have depleted somatic proteins, but their visceral proteins are normal. So that is why when you take blood values for, because the visceral protein are normal, when I say visceral protein, the proteins in the organs. So when these protein, when you take a blood test, you'll find a normal albumin and transferrin in such patients. But when we look at them, they will look thin and malnourished. So example of such patients are patients who get admitted to an hospital with mild to moderate mass starvation, severe burns, injuries, systemic infection, cancer, etc. So even a patient who was anorexic may be included into this category. So what are the clinical manifestations for marasmus? You can see that these patients have severe weight loss. They have reduced basal metabolism. So basal metabolism is that nothing but it is a term which measures the calorie which requires for the normal activity like breathing, like respiration, and normal involuntary actions in the body, like your digestion, absorption, circulation, respiration. So these are the basal metabolism. So even this, there will be a reduced basal metabolism, which you can find out using a metabolic card. But unfortunately, most of the hospitals here, we don't have a metabolic card. But I think few hospitals, one Fortis hospital in Bangalore has a metabolic card, but most of our hospitals, we don't have a metabolic card here. And these people have a depleted skeletal muscles, and your fat stores are gone. Skeletal muscles, you can always see they have a depleted fat mass in your clavicle bone, your temporal region, So all this, and your adipose tissue, you can use your caliper and check this. All these can be checked. And decreased tissue turgor. So you feel like they look older than their age, biological age. They have bradycardia and they are hypothermic. So bradycardia, where they breathe, they can breathe like you would have seen panting kind of a breathing. And then hypothermia, where the temperature of the patient also will be lesser than the normal. So this would be exactly what they look. This is, of course, a very severe case. But hospitals, we don't get such very severe cases, but we do get severe. We had a recent case which was not very bad. Maybe the person who looks, the lady on the right, somewhere like that. But we don't get children so bad in our hospital setup. So then kwashiorkor, the next kind of malnutrition is a kwashiorkor, which is nothing but a protein malnutrition. So here the diet contains various amount of non-protein calories. So which means the adequate of intake of calories through carbohydrates, fats are adequate, but the calories through protein is less. So these people don't take enough protein in their diet. So here they have normal somatic protein, but depleted visceral protein. In marasmus, you have your visceral protein normal. That is, the protein stored in the organs are normal, but outside of the cells, it is abnormal. But here, the outside cell somatic protein looks normal, but the visceral proteins are depleted. So here, that's why in the blood values when you take, you can see in the albumin, they have decreased albumin, where the albumin level will be less than 3.5 and transferrin levels. So transferrin is again an indicator for your immunity, okay, and your nutrition. Here, one thing I have to place on record is that transferrin is definitely a good marker of whether a patient, to state whether a patient is malnourished or not, better than serum albumin, because albumin takes 21 days to show the effect, but transferrin takes about 12 days. So this transferrin is a better marker, but in hospital setups, we generally don't use this because it's very costly, and that is why we don't use much of it, but albumin is a regular indicator. So here the patients appear normal or overweight. So that is the you would have seen the marasmus kids, they look normal except with the pot belly. So you can easily identify them. So these patients are an example of hypercatabolic critical care patients, chronic diarrhea, chronic kidney disease, trauma, burns, hemorrhage, liver cirrhosis. So all these cases, these patients are protein depleted. So clinical manifestations, marked hypoalbuminuria, albuminemia, anemia will be there. All of you know, the first indicator for kidney disorders and liver disorders is the patient getting anemia. Then edema and ascites, all of us can see such patients will have pitted edema. I think you would have gone through. So your legs will, the legs will be swollen, and when you make put your finger on top of it, it just goes down, and it will take a longer time to come up. That's called pitting edema. Okay, muscle atrophy, delayed wound healing, impaired immune function. So all these patients will have such diseases as clinical manifestations. So now, yeah, this is the picture you can see. I'm sure most of you would have come across such cases walking around, especially in children who walk around the street, or patients, mostly in children who are in orphanages. I've come across children. They look healthy, but only think their tummy will be big. So we do deworming for such patients and see. But when we look into the parameters, we see that their iron values are less, their albumin values are less. Then we come into a conclusion that protein intake is less. So this is very common in hospital setting. These kind of patients are very, very common. Those with pancreatitis, those with the chronic liver diseases, those with alcoholic liver disease, fatty liver disease. So all this you can see such a site inside the hospital also. So yeah, so when you come, when a patient gets admitted into a hospital setup, they have mixed, that is marasmus and kwashiorkor together. So we don't see a particular, we cannot differentiate between whether they were marasmic or they had kwashiorkor. We consider them as both mixed, marasmus and kwashiorkor. So what are the medical causes or risk factors for malnutrition? Now we know that the different kinds of malnutrition and why does it occur? What are the clinical manifestations for the same? Now, what are the causes for medical causes for malnutrition? Causes for malnutrition are different. I'm sure since sir told that from the Agriculture University also you have members, eminent members talking, they would have addressed about feeding difficulties or lack of fortification and things like that. From medical point of view, the causes of malnutrition are the patient undergoing a recent surgery or trauma, sepsis. Sepsis means where there is multiple growth of various organisms like bacteria, fungi, or virus inside the blood. Chronic illness, like your chronic illness, you can classify as diabetes, kidney disease, alcohol liver disease. All these are coronary artery disease. All these are chronic illness. Chronic is something which has been with you for a longer time. Acute is something which occurs then and it goes off, right? And then gastrointestinal disorders. It could be your irritable bowel syndrome, your ulcers, or Crohn's diseases, or all those kind of GI disorders. Anorexia is nothing but an eating disorder, dysphagia, lack of hunger, recurrent nausea, vomiting, diarrhea. Pancreatitis. So pancreatitis is nothing but the inflammation of pancreas, and all of you will know that pancreas is an organ which secretes insulin. And then inflammatory bowel disease, where your bowel lining gets inflamed due to microorganisms, infestation by microorganisms. Gastrointestinal fistulas. Fistulas are nothing but a bulge which is filled either with various kind of body fluids, and of course cancer is a common term. Now, see, one thing all of you should understand. See, everybody has a doubt. See, when a patient what is the differentiation between the normal starvation? See, you will have come across your parents, grandparents, or you yourself will be, go under that is willingly you take up starvation due to some religious reasons, or you want to reduce weight, you go into starvation. So in such cases, there is a difference between normal starvation and starvation during a illness. So this is why this slide has been put here for you. So you can see that the resting metabolism, which I am talking about, that is the resting metabolism, to re-emphasize, is nothing but the metabolism which happens during your rest, where you breathe, where the circulation happens, where there's respiration happens, where there's cardiac function happening. So that's a resting metabolic rate. So the resting metabolic rate, you can see that even by the 10th day, the metabolic rate for a sick patient, especially for a person who have undergone burns, you can see the respiratory rate is around 160, 180. So it is 80 times more than the normal. And this is sepsis, this is trauma, okay? But this is, when you're starving, you can say it is below normal. The body gets used to it, or it adapts and it goes to metabolic rate which is lesser. So the amount of, the protein you lose or the muscle mass you lose will not be there, because the body itself adapts and it stops such a thing occurring. But when a patient body is at a trauma due to physical illness, you can see that the amount of the metabolic rate is 8 times to 10 times more than the normal. So when I say when the metabolic rate is more, so much calories and protein are lost from the body, and we need to replenish them immediately, or the patient, we may lose the patient also. So then is protein catabolism. You can see that nitrogen excretion per day. So it is nitrogen excretion per day, and here is number of days. You can see that in major burns, nitrogen excretion per day is somewhere above, nearly 30, somewhere between 25 to 30, and 25 to 30 grams per day. So which means you have to multiply the number of grams of nitrogen into 6.25 to get the number of amount of protein. So per day, when you convert it to protein, a patient who's undergone a major burn, he will lose around 187 to 188 grams of protein per day. I'm not talking about month or week, but it's per day he is losing. Even you can see the trauma, that is, patient under trauma, it could be when what is it, an accident, or it could be a stroke or whatever. So in this case also, you can see that he loses around 20 grams of protein per day. So where are we? So in case the nutritionists don't buck up fast, we have to act fast. That is why we insist, all the dietitians are insisted that we take care of this part, okay? That is within the 5 days of admission, okay? We have to buck up, otherwise we lose the patient's lean body muscle mass. And lean body muscle mass, once it is lost, you cannot get it back at all. And this is very important, especially during a stage where immunity is most important for us. So this is the window period which we have, you know, between the 0 to 5 days. And this is the time where the dietitians have to buck up and feed the patient a lot of protein and enough calories to protect the protein for its own function. So this is how what fooding has to be done. So the goals of nutrition support. So now you understand from the graph itself that why nutrition is very, very important, acting very fast on patients who are admitted to our hospital is very important. Why? Because only then the mortality is nothing but losing a patient due to death, and then we should reduce complications and infection. That's mostly required, because the patients, we have seen a number of patients who would have been normal outside but very frail. So when they walk into the hospital where we have number of patients of different care, various patients of various kinds and diseases around, they tend to catch the other person's infections also. So that also we need to take care. That's why I said protein, giving them protein immediately within 3 to 5 days is very important, because once they lose the lean muscle mass, we lose the patient. Then reduce the catabolic state and restore anabolism. Of course, catabolism, all of you know, losing of calories, protein, muscles, etc. Anabolism is synthesis of calories, protein, etc. So, and decrease the hospital length of stay, which is most important, because in a economic status like India, I think every day, okay, we will lose, every 5th day we lose half the salary of an individual, whoever it may be. In case it is a patient with cancer, he may walk in, I've seen cases to walk into the highest paid room in the hospital, and as they come back for the subsequent admission, they go into the general ward bed. So that's how it is. That is the state. So that is the reason all of us should join together and understand the importance of feeding a patient and taking him healthy back home. So speedy healing or recovery process. For all this, you need good nutrition support. So when there are two, when a patient gets admitted to hospital, we have to identify if the patient requires aggressive nutritional support or not. When I say aggressive, I have only two terminologies here: whether the patient has to be fed through the enteral route or the patient has to be fed through the parental route. So when any one of these parameters, which I'm going to list it down, if the patient has any 3 of them, then I have to feed them aggressively. So what are they? That the patient looks clinically malnourished. I just listed down how we clinically look into it. How if a patient has a low serum albumin level less than 3.5 milligrams per deciliter, has a recent loss of 10% of weight or greater, has a history of recent poor intake, who as a consequence of illness is going to be or is likely to be on nil per oral, which means I don't feed the patient. I anticipate that I don't feed the patient, or the patient cannot be fed for 5 to 7 days, subsequent 5 to 7 days of admission. Then I will have to feed the patient parenterally or enterally. Okay, so this is a golden terminology here, which all of us should understand. If the gut is working, or if your system, your esophagus, your stomach, etc. is working, please use the gut. And if it is partially working also, try using it partially, because if the gut is not used, what will happen is the usual microorganisms in the larger part of the large intestine will be converted into harmful bacteria. They enter into the bloodstream and they can cause a hell of a lot of inflammation and infections. So this is a this is a nutritional assessment which you generally do it. Here what we do is we take a medical and nutritional history. So medical history will be available in the case file itself. Whether the patient is admitted for which kind of a disease, whether it's acute or chronic disease, what are the medications the patient have, what is surgery or any procedure the patient is going to undergo, whether he is going to if not surgery, what are the other therapies which he's going to undergo. So all these are the things which will be available in medical history. Then we go and take the nutritional history of the patient. So nutritional history includes changes in the appetite, weight loss, whether what was his functional activity, was able to do his routine activity, was he able to go cook, is a dentures okay if the people are old, you know, those kind of things. Even dentures matter a lot. Believe me, the people who are older, they go into micronutrient deficiency, especially because they have they do not have dentures. And all of you by now will know that carbohydrates are absorbed by the saliva. And in case these people are not able to chew, definitely their absorption of nutrition is not 100%. And if all of us take light, you would have also laughed when I told you why should they say dentures, but dentures have such a lot of significance attached to it as well, and nutrition is concerned. That's why you see all our old age people are frail, especially those who do not have proper dentures. So, and we use something called the subjective global assessment to assess the patient. I'm not going to go into details because you're just when you come to PG, you will understand that better. Okay, so physical examination, I've gone through all this because simple terminology there, where I look into the pitting edema, where I look into the body mass index. Yeah, right. So yes, all this I'm just skipping out because we use this only for research purposes. When it comes to day-to-day routine, we don't use mid-arm circumference, we don't use TSF, we don't use all these tools here to assess. The only tool which we use is the subject global assessment format, where we take into account the patient's food intake, the patient's mobility, the patient's recent weight loss, the patient's the edema status, the patient's GI status like the nausea or diarrhea, vomiting, and the things like that. So these are the things we're taking into account. We have no time to address into this MAC or mid-arm circumference or trifold skin fold thickness, because all this definitely it has become outdated now, and we use it only for research purposes, because there is something called a body composition analyzer which has come already. So when you stand on that, it gives you everything including your body water content. So these tools have become outdated, so I don't want to waste time on this. Yes, so now this is the nutritional roadmap. So when I assess the patient using the subjective global assessment, and I find that he has a functional gastrointestinal tract, if it is yes, okay, then I go opt on the enteral nutrition. So one thing I have to emphasize here is enteral nutrition includes oral nutrition also. So when it's oral nutrition, I go for standard nutrients, okay, and if the patient is adequate intake is there, then I continue feeding the patient orally. But there is another category which is called inadequate enteral nutrition is there. So in that case, I insert a tube into the patient and start feeding the patient with the initially I just again try feeding the patient with any supplement. You would have heard of various supplements which are available. I'll detail it in my next slide. So I try and use supplements for them, like protein supplement or calorie supplement, fat supplement for them. It's still the intake is inadequate. I progress to total enteral feeding, which is nothing but tube feeding. Okay, now if the gut has even in enteral feeding, tube feeding, there are specific specialty formulas used. For example, if I feel the patient has diabetic, I try and use a diabetic formula where the carbohydrate is less. Okay, the calories from the carbohydrates are lesser. They have more protein in their formula. Then if I feel the patient is having liver impairment, I go into a formula, specialized formula for liver, because when I say specialized formula for liver, these formulas will have branch chain amino acids in them, okay, with double the calories, okay, 1.5 times the calories. The normal formula will have 1 kilocalorie, a diabetic formula will have 1 kilocalorie per ml. For a calorie for a liver patient will have 1.5 kilocalorie, because as it is they'll be nauseated, the intake appetite is less. So with the same ml, I'll be able to give 1.5 times the their calorie requirement. So I prefer using that, and they have branch chain amino acids for them. And all of you will know that branch chain amino acids are good, are absorbed better for a patient with liver impairment. Then if a patient has got renal impairment, they'll be on dialysis. So you saw how much of protein is lost, 180 grams approximately. Okay, so when that so much protein is lost, especially during the dialysis, we need to give them more calorie, more protein. So such formulas will have 2 kilocalories and a lot of protein, say 1.5 to 2 grams per kg body weight of protein in them. And some patients who are on inotropes, when I say they are the critical care unit, they are very sick. Such patients will be totally sedated, even their bowels won't function properly. In such cases, I prefer feeding them with a peptide formula, a formula which is totally digested, but not parental route. It is a totally digested formula, sugar in the form of glucose, then protein in the form of peptides. All of you would have studied that is the shortest form of protein available, and oil is in the form of medium chain triglyceride. And one thing people should know that MCT oil does not require any kind of digestion. It can just get absorbed from the skin itself. So that's how it is. So no absorption route is required. So such formulas can be used for people who are really cachectic and who cannot digest nutrients properly. So that's about the specific formulas which I consider. Now, if the gut is not function, I go to the next alternative road, which is nothing but parental nutrition. In parental nutrition, we have short-term parental nutrition. We have we use it for suppose we need to build the nutrition for the patient before the surgery. Then I opt for the giving. And he was not eating for past 5 to 7 days before admission. Then we put the patient on short-term. Then, and the route followed is a peripheral line. All this I'll be detailing in the subsequent slide. And then if you want long term, in some cases like where you're due to cancer, there's totally few organs have been removed, then the long term parental is required. Then the central only can be used. And in both the cases, we view the patient. In case the patient gets okay within 7 to 10 days, we go back to enteral route. So this is the nutrition roadmap. Now, so what are the indications for enteral nutrition or tube feeding? When a patient is his inability to consume or absorb adequate nutrition. So those people who do not eat or receive nutrition support for more than 10 to 14 days after hospital admission. So then we give them feeding through the tube. Then functional or partially functional gut, who are unable or not allowed to eat. For example, some would have gotten oropharyngeal procedure done due to accident or cancer or whatever. So then that case is also we insert a tube and start feeding the patient. Now, benefits of giving enteral nutrition: nutrients are metabolized and utilized more effectively via the enteral than the parental route. So one thing you should understand, though tube has been inserted, it is going into the stomach. So this tube is doing only the function of the esophagus, which is nothing but a pipe. Okay, so you're putting some food into the pipe and it goes directly into the stomach. So there's no major alteration in the metabolism for such patients. So you can treat them normally. You can give them the normal kind of nutrient combinations. Okay. Then the gut and the liver process enteral nutrition before they are released into their systemic circulation. Correct. So since as I told you, there are no major alteration occurring in their metabolism or digestive enzymes secreted or absorption capability. No, it is the same as you take it orally. Only thing, instead of going through the mouth and the esophagus, it goes through the nose tube into the stomach directly. So in this, definitely the gut integrity is maintained. So that is very, very important. All of you should understand. That's why I put this separately here. Unless you feed your gut, which is especially the microorganisms at the colon region, there are a number of detrimental effects which will happen. A patient on tube feeding also can end up in diarrhea or constipation only because we don't feed those bacteria properly. So, and there are now newer theories which they are correlating with giving good microbial therapy for patients who are sick. Yes, these are the various tubes. A tube which is inserted through your nose, which goes up to your stomach, is called the nasogastric tube, which I was talking about. Okay, so patients, this site is mostly seen in most of the ICUs or in wards. Okay, but some patients who have to be fed for a longer time, or this whole esophagus has been eaten away either by cancer, or the patient has abused himself with some acid drinking or something, where this whole area is lost. Then we put a tube into a small surgical procedure is done in the stomach region. A small tube is inserted into the stomach, and we start feeding your nutrients into that. Something like you can imagine yourself filling petrol. There's a pipe out here where there's a nozzle where you put the petrol into the petrol tank. Something similar to that. Similarly, it is the nasoduodenal tube. Instead of the stomach region, where suppose most part of your stomach has been, cannot be used due to various reasons. Okay, cancer or some severe infection or gangrene, things like that. When this part has been totally taken out, the only left part would be your duodenum, which is nothing but a extension, lower end of your stomach. And then we insert a hole into this place, insert a tube, and start feeding the patient into the duodenum. So in duodenum, mostly, gastric region is something like a mixer. All your nutrients are mixed together with the stomach acid. So since your gastric region is lost, you're feeding the duodenum. So here you need to select a particular formula which does not require mixing up or with the juices or the acids. So here you can try giving the patient some semi-digested formula. Okay, then you go into the jejunum region. So in this jejunum region, where the whole area has been lost due to some illness, then you go feed the jejunum. Here, children, you should understand that jejunum is a site of absorption. There's no digestion happening. Absolutely, it is a site for jejunum. So when you're feeding the jejunum, I told you a formula which is based on peptide. Peptide is the only formula which will be totally absorbed. Okay, but if in case this jejunum has been converted into a sac like this by a gastric surgeon, after maybe a month, that jejunum also will learn to work like a stomach. Until then, you have to use only pre-digested formula. Maybe after a month, once it gets adapted, you can go to a normal formula. But feeding a jejunum, only peptide formulas can be done. Similarly, a jejunostomy tube, same thing, a surgical procedure. In nasojejunal, the tube goes from here to the stomach for nasogastric, from through the nose into the duodenum for nasoduodenal, from the nose into the jejunum for a nasojejunal placement. So the nasojejunal nasal tube placements can be done in the critical care unit by the nurses itself, but ostomies, gastrostomy or jejunostomy, etc., would require a intervention from a surgeon. Yes, so this will be the physical pictures. You can see that the PEG tube, you can see this is the three kind of tube which will be available. This is the outer skin of the stomach. Ostomy or a hole is done here, and then the tube is inserted into your stomach. Now it has gone into the duodenum. So it goes to this. So this is your PEG tube. This is how it looks from outside. So patient, when you have, so for a patient who's got a gastrostomy or jejunostomy or duodenostomy. This is the kind of feed. Only the sides will go down. Okay, this is gastrostomy. So jejunostomy will be something. Duodenum will be like this. But from outside it will look the same. So this is the end where we feed the patient. This is the tube which is inside the patient. For nasogastric tube, you can see this tube is inserted. It just goes and it is lying here. And a patient would look like this. So there's from the tube, the outside the patient will look like this. So this is how it will look, right? So for short term, you can use nasal feeding. For long term, you have to use ostomy feeding. Yes, this is how all of you in critical care unit, since most of you cannot visit during the pandemic, that is why I put these pictures here. You can see this. This is the kind of a feeding bag where our nutrition is poured into this bag and it is hung like this. Okay, so this you can see this is a feeding bag, and from the feeding bag it goes into a feeding pump, because if feeding pump is not used, you can see a clamp here. If the clamp is open, at a time the whole feed will go into the patient's nose, and the patient can aspirate and he can die also. So that is the reason we insist that they use a feeding pump like this. So it is like something you have seen in all the hospitals. You would have seen those IV fluids going through an infusion pump, something similar, but it's called a feeding pump. So while the solution is poured, the cap is open. Okay, the solution is poured into it. Whatever ml, you can see the gradation here. You can see it could be 1,000 ml, 2 liters, or 500 ml, whatever. Pour the feed into the bag, hang it. It goes through the infusion pump here, and you set how much ml. For example, you can see here 60 ml per hour. So you set with the it is all what is it? You can say buttons are there available, or microchips are available. You have just set 60 ml per hour, and you shut this lock here, and the feed will start flowing. The nurses need not take much care of it. Okay, so this is how continuous feeding happens in a hospital. You can see bolus feeding. Okay, when a syringe is put from the thing nose, there is a tube coming out. Okay, the nasal tube. The nurse takes the solution into the syringe and she pushes the solution into the tube. This is called a bolus feeding, and every 2 hours the patient gets fed, and this is called a continuous feeding, where throughout the day, starting 24/7, the patients are fed through this. This is called continuous, and this is called bolus, where every 2 hours only the patient will be fed. So hope you understand that. So benefits of enteral nutrition. Basically, we use the gut, which is very, very, very important. That's why I repeatedly use the term gut. It has to be used, because otherwise you would have learned about villus. Okay, the villus strength, that is the absorptive side. If that is gone, if the length, it keeps decreasing every 5th day, it keeps decreasing. If you don't feed the patient, the length is totally gone, and later on, whatever you feed the patient, it will not get absorbed at all. So that is the reason we have to feed the gut, and that's why we say feeding the enteral nutrition is beneficial, and it is less hazardous than parental nutrition, because you are feeding through the nose. Only thing, we have no direct contact into the bloodstream of the patient, so definitely it is safer and it is cost effective. One enteral nutrition bag costs around 600 to 800 rupees, but when it goes to a parental bag, IV fluids, it goes up to 1,600 to 2,000 rupees. So definitely it is economical. Okay. So, but there are certain areas where enteral nutrition cannot be used. What are they? A patient is very sick, terminal illness, short bowel syndrome, where the bowel length of the bowel is very less, so there's absorption is not possible. Obstruction in the bowel, GI bleeding. So even when your gut is bleeding, gastrointestinal tract is bleeding, you cannot feed it, because if you feed it, you're going to insult it and bleeding will be more. So you need to give a rest to the bowel. So in such cases, then there is excessive vomiting, diarrhea. Even during pregnancy, gravidia, they have emesis. So in such cases, also parental nutrition has been used for patients. Fistulas. The fistula means it will be leaking always. So there's no point in feeding enterally. Ischemia, where the bowel is totally gone, it doesn't function. There's no blood supply to that area at all. The whole organ becomes black in color. So you cannot feed that area at all. EVS, EDS is that again there is a temporary shutdown of blood supply to the particular area, and the particular area doesn't function at all. Inflammation, all of you know what an inflammation is, and pancreatitis, where your pancreas has been inflamed. So in such cases, we do not feed the patient through enteral route because we do only parental nutrition. So what are the complications in enteral nutrition? Definitely enteral nutrition has its own complications also, because as I showed you the pictures, the presence of a feeding tube itself, it causes sinusitis in the long run. But nowadays the companies have come up with polyurethane tubes. So there where the tubes are very soft. Initially the tube used to be, there are different sizes also for the tube. It used to be very 12-inch tube, and now it used to be very thick. Okay, so the patient used to feel very discomfort, and then sinusitis occurs for this patient. So tube clogging, if the nurses are supposed to flush in the food, then flush in water, then only close the tubing. If that is not done adequately, properly, then clogging of the tube occurs. So where you have to remove the tube again and reinsert, which is definitely a problem for the patient. Then declogging methods, yes, the patient has to cough it out. They again cough it to take it inside, swallow it to take it inside. Definitely it is a problem for the patient. There is aspiration. So what happens is, if the tube is not, the patient while sleeping, he might pull it out. Then the sisters won't know. The next day, if they don't osculate, they usually put a stethoscope and check in the chest to hear if they hear a weird sound. In case the sound is weird, then they have to do a bedside X-ray to check if the tube is in the stomach or elsewhere. If they don't do it, and sometimes if the tube has been dislocated to the lungs and you start feeding, the patient will definitely die of aspiration pneumonia. Okay, so GI complications. You have gastroesophageal reflux. Yes, some patients who do not tolerate, they just keep on burping it out, and diarrhea, metabolic complications. All these are complications for feeding the patient through a tube. Of course, the other could be your metabolic complications could be hyperglycemia, because definitely, as I told you, the formula is calorie dense. So the patient, if the dietitians don't tighten the calories adequately, the patient sugar gets shoot up beyond 250. Electrolyte and mineral deficiency can occur. This especially occurs when patients are fed with kitchen feeds. So that's why we insist that you use only formula feeds, because all formulas have micronutrients, adequate micronutrients in them as per recommended dietary allowances, but kitchen feedings will not have it. And refeeding syndrome is nothing but a patient who are not previously eating well. Now the dietitian pushes so much calorie into the patient's sodium can drop, potassium can drop, the phosphorus can drop, and the patient can even, it can be even fatal to a patient. So it is very, very important that they start slow. If you feel the patient had lost more than 10% of the weight, then we advise that we start the patient with 25 kilocalorie per kilogram body weight, and then go up to 30 calorie per kilogram body weight. So in ICUs especially, all of you should understand hypocaloric feeding, lesser than the normal, but 2 grams per kg body weight protein. So double the protein with hypocaloric feeding is what is expected when a patient is in the critical care unit. So now, enteral nutrition, hope most of you have understood. I've made it more simple. And now it is parental nutrition, where you give all nutrients in the form of, calories in the sugar, carbohydrates are given in the form of dextrose, and then protein is given in the form of amino acids, then fat is given in the form of lipase, and all the minerals and electrolytes are put into the bag. Yeah. So we all saw the indications where parental nutrition is a must. For example, your Crohn's disease. Then in Crohn's disease, nothing but they have an allergic to your gluten, okay, and all your large intestine, something like an ulceration happens in the large intestine. So such cases cannot be fed orally. This is chronic, I would say, and esophageal carcinoma, paralytic EVS. So all this we have seen earlier also. So in certain cases where food cannot be immediately and completely absorbed, especially in burns cases, okay, the total system is paralyzed, okay, such cases, especially those who have burns beyond 30%, definitely parental nutrition would be a better choice for them. Okay, so after a major surgery also, in case we call it a ripples procedure where a number of organs have been stitched together, such cases also we prefer parental nutrition. Okay, yeah, and for patients who feel we cannot feed them enterally or orally for more than 5 to 7 days, then we put them patient on a parental nutrition. So how do you administer them? Yeah, so to administer, you should know the various sites. Okay, so you are talking about central line and peripheral line. So this picture is very simple and very clear. You can see that those which is near your heart, okay, directly near your heart, okay, that is the internal jugular, the superior vena cava, the subclavian vein. So these are the arteries where you put your central line. So you can see the proximity to the heart. So you can the amount of the force, or you can just imagine the force with which the blood is pumped out into this artery. So this is the area which is punctured to, and it is called the central line. So these are near your hand. Okay, so you can see the distance between the heart and this area. So you here, these are called the peripheral lines. That's why it's called the peripheral lines. So in these, the blood flow, the pressure with which the blood comes out maybe is definitely lesser than these areas, and we call them a peripheral line. Okay, the cephalic vein is mostly used. The brachial or the cephalic vein is mostly used. Here, this is the when the line has been put here and nutrition is given here, we call it peripheral nutrition. Where a puncture is done here and nutrition is given here, it's called the central nutrition, central vein. So in central nutrition, as I told you, it is given to the subclavian vein. When you want to feed the patient for more than 5 to 7 days on parental nutrition, we give them central nutrition is always better. Hypoosmolar solution, where your osmolarity is more than 900 milliosmoles, which means your dextrose concentration is 50% concentration. So such cases, you can, when you give a concentrated dextrose solution through the vein, believe me, the whole vein will be burnt. Okay, it is no joke. So that is the reason where osmolarity is very, very important. And one more point here is, when you give lipids along with dextrose, the osmolarity generally goes down. That's why you have seen who has had opportunity to see, you can see 3-chamber bag where there will be lipids, amino acids, as well as dextrose. But there are 2-chamber bags also available for patients whose triglycerides are very high, where we cannot give lipids. In such cases, only central line can be given, because the osmolarity of such solutions are very high. And if you give it through the vein gets burned, and you can outside, you can see that even when you give a blood test, you would have seen on kind of a black patch, right? Similarly, black patch are bigger sign of patches occur, which is called the thrombophlebitis, and the vein gets bulged. So that is the reason where central nutrition is used when you give hypoosmolar solution. And the minimum volume is, so minimum volume means your osmolarity is high and definitely expensive, and there are side effects. When I told you, I told you before, it's very near your heart. So if you any infection which occurs through that line will definitely lead to sepsis, nothing less than sepsis. So that is the reason you should be very careful when you're using a central line for patients. As far as, and it requires, of course, a surgical intervention in the theater. It is not done at the ward side at all, because it has to be done in aseptic conditions. And peripheral nutrition, of course, I told you the peripheral line. When you feel you need to feed for a lesser period of time, and the patient can go into oral enteral nutrition later, you can opt for this. And when your osmolarity is less than 900 milliosmoles, and the nutrient required is minimal, so it's not more than 1000 calories, then we opt for this. And large volume is allowed, and thrombophlebitis can occur. So as I told you, that becomes a dark patches occur because the vein has been burned. So thrombophlebitis occurs in peripheral nutrition. So you use peripheral nutrition only when you have 3-chamber bag, that is lipid, amino acid and carbohydrate, and use it when you have, you can feed for a shorter period of time. Yes. So I think we have gone through all this. It is just a repetition. So you can see that in central TPN, the osmolarity is around 2000 milliosmoles, but the osmolarity to the peripheral is less than 900. But in this case, we will be able to give the full nutrition to the patient, unlike the peripheral nutrition. And the disadvantage here, I told you, it requires a surgeon's intervention. The patient can enter into sepsis if not taken care of properly. For peripheral parental nutrition, okay, so this is for adults, it is 900 milliosmoles per liter. Okay, so the advantage is that line can be put in the critical care unit or the bedside itself. Okay, the risk involved is very less, but they have other complications, like it's definitely painful. A patient cannot move this side or that side. Okay, so it is definitely painful, and the amount of calories you render, calories and proteins you can give through a peripheral line is far lesser than that you can deliver through a central line. And this is very important for people who aspire to practice. You can always give a peripheral product through a central line, but you cannot give a central product through a peripheral line, okay, because of the osmolarity, which will end up burning the vein or the vein of the patient. Yes. So I think this, being a BSc student, it may be a little too much for you. So I'm just going to skip this slide for you. So what are the monitoring you have to be done for a patient who is on parental nutrition is, you have to look into the glucose for the patient daily, because dextrose, immediate sugar, is fed into the veins. Definitely there will be rise in sugar. So this has to be done daily. Your electrolytes have to be done daily, your minerals like phosphorus, magnesium, creatinine, calcium, blood urea nitrogen should be done initially thrice a week, then weekly once. Your triglyceride definitely weekly once, because this is the indicator to tell me whether I need to continue with my lipids or not. This is the fluid requirement, which has to be checked every day, because first I start with 1 liter, then I progress to 2 liters, then 1.5 liters, then I progress to 2 liters. I don't go more than 2 liters. So fluid monitoring daily is required. Check the temperature of the patient, because very important, as I told you, especially when central line, if there is an infection, the first thing which shows outside would be your redness, and second is the temperature of the patient. If both are found out immediately, we have to check the line. Okay, and of course your LFT, the liver function test, where bilirubin is checked for the patient, and check the body weight of the patient every week, because we need to know whether we are overfeeding the patient. If the there's fluid overload, the weight of the patient will keep on increasing. So that's again an indicator that I'm feeding more to the patient, and it's a very inexpensive and a simple indicator. So weighing the patient who are on parental nutrition every day is a must. Okay, so as I told, we dealt about refeeding syndrome also. That is, I told you earlier. In case you feel the patient was totally malnourished, please don't be in a hurry to feed the patient, because the patient can end up in refeeding syndrome, which is definitely fatal. Okay, and in case we give more calories than required by the patient starts showing glucose intolerance. The sugars will shoot up. You may think, let the sugars shoot up, I don't give insulin. No, as the sugars shoot up, soon wound healing will be delayed, infections will set in. So that is the reason we have to tightly monitor the glucose. By and large, our target is keeping the blood glucose below 150 milligrams per deciliter. So these two things are very important when you practice as a dietitian. So electrolytes will tell me whether I'm feeding the patient properly or not. You will not believe, sodium or potassium are very good indicators to show you directly that you're feeding the patient properly or you're underfeeding the patient. In case there is an imbalance in sodium and potassium, okay, then it is a very direct indicator that the patient is either being fed less or fed more. So please review your prescription and alter accordingly. And serum triglyceride, I will be very concerned only when I give parental nutrition. In enteral nutrition, triglycerides don't increase as much. So even liver function test, especially I look into the liver function test to check about the albumin to see if the patient is stressed. Albumin, again, I'm insisting, is not an indicator for malnutrition, but in case the patient has to be taken for a surgery, just as an broad indicator, we can see into the albumin. In case it is below 3.5, we can always safely tell the doctor that the patient will have delay wound healing. So better we wait, give more nutrition and then take the patient for procedure. So complications, so mechanical complications, yes, catheter, the patient can remove the catheter accidentally, then thrombosis, pneumothorax, yes. So in case the central line is not appropriate into the artery, it is because the patient has moved here and there and gone and punctured the patient's lung. It can lead to pneumothorax, where air accumulation can occur and the patient can die also. Okay. Then catheter infection, which can be treated, understood by knowing the temperature of the patient, and refeeding syndrome, hyperglycemia, fluid overload. All this I have discussed. Yes. So now, how do you transit from the parental nutrition to enteral nutrition? You just cannot abruptly stop parental nutrition. So when your parental nutrition has been started, you can you want to switch over the patient to tube feeding. What you do is you give 1/3 through parenteral, the rest you give through enteral. So now next the patient tolerates, you cut down the parenteral to 50%, you give the rest 50% through enteral route. Okay. Then the third day you increase your enteral nutrition calories, you decrease your parenteral to 25%, and then finally the fourth day you just give them dextrose, 5% dextrose, and then stop it totally. You cannot abruptly remove the line and then stop it. The patient can go into hypoglycemia. So by 4th or 5th day, you taper it to give 5% dextrose, and full volume of enteral nutrition can be given, and you can totally transfer the patient from parental nutrition to enteral nutrition. So thank you for listening. I hope I just made it as simple as possible. Still, if you have any doubts, you please ask me.
Thank you, ma'am. It was very lucid talk. I hope students have understood what you are trying to speak up. It was a very useful session. Yes. Now the floor is open for interaction. I request the students to either write your questions on the chat box or unmute your mics and speak up to the resource person.
Good evening, ma'am.
Yeah, good evening.
What type of nutrition is followed immediately after a bariatric surgery, ma'am? Because recently I came across a case study on bariatric surgery, and they had started immediately on enteral nutrition. Is it possible, ma'am? Because it's a gastric bypass.
Can you come up by bariatric surgery? You want to know what kind of nutrition is immediately given
after surgery?
After gastric bypass.
Gastric bypass, yeah.
Okay. Yeah. So gastric bypass, immediately after gastric bypass, what we do is we put the patient on NPO, okay, nilperoral, for that particular day. The next day, the patient is taken for gastrographic study, where we see if the gut has started moving, motility of the gut is there is no retention. Then we start the patient on clear liquids on the first day. So in clear liquids, we don't give them anything. We devoid caffeinated beverages. We devoid sugar for those patients. Okay. So once they told, and the particular thing here they should understand is they should be taking it in sips. They cannot use a straw and then gulp it. They used to be, we give them a spoon, so then they take it in sips. Okay. So once that is through, the third day we put the patient on full liquid diet. Again, there is no coffee tea, there is no there's juices without sugar, and there is no carbonated beverages. Okay. Then after a week we start them on puree diet. Then after the 2 weeks we start them on soft diet, semi-solid diet. After 1 month we start them on solid diet. After starting on solid diet, 3 weeks after starting them on solid diet, we put them to normal. So by the time they come to the normal diet, it will be nearly 1.5 to 2 months.
Thank you, ma'am.
Both the students understood. Was it simple or was it were they able to understand?
It's quite simple, ma'am, because third year they started on dietetics, and
First PG also here.
yeah,
We
they
have
started
30
PG this year.
30 students of MSc first year is in the group.
Okay, okay. Maybe they understood everything. That's why they don't want to ask questions, or they didn't understand. There are only two reasons why there's no questions.
Training, ma'am.
Yeah.
Ma'am, the patient with severe ascites and diabetes mellitus for feeding, how we restrict fluid, ma'am?
Patient is having diabetes as well as ascites. What is the question?
How we restrict with the fluid, ma'am? The patient with the diabetes and ascites for feeding methods, how we restrict the fluid balance, ma'am?
You want to know how they adjust the fluid, is it?
Yes, ma'am, for feeding.
Okay. Is it? I mean, for ascitic patients, you know that water will be tapped out for the patients, and based on that, we will adjust the fluid and fluid, especially the amount of based on the drain. The doctors will let us know how much volume to be fed, because here the dietitians cannot calculate. It is we require the doctor's guidance on this. Only they will know how much fluid has been tapped out, how much ml the drain has been measured. So based on that, they let us know. And fluid restriction, if at all fluid restriction is there, we don't, we just, I mean, the usual gravies we don't take into account. Those patients who are on oral diet, we just calculate the water which they take, and juices, anything which is liquids at room temperatures like juices or shakes and things like that, plus your oral supplements and rasam, those kind of things are taken into account. But rest of the gravy kind of the thing, we don't ask them to measure. So it is not so serious. But if it is enteral route, then definitely doctor will tell us so much of fluid only. If it is 800 ml restriction, then I calculate my formula based on the 800 ml. Because as I highlighted to you earlier, for liver cases, the calorie will be 1.5 times. So like that, I will be able to meet the calorie of the particular patient.
Thank you, ma'am.
Good evening, ma'am.
Yeah, good evening.
Is there any commercial formula for parental nutrition, ma'am?
If your question is right, you're asking me if there's any commercial formula for parental nutrition.
And the name of the commercial formulas, ma'am, which we use now. Parental
You're asking the name for?
Name, ma'am.
Name for parental nutrition bag.
The formula which is being administered parentally.
Yeah. Yeah, there are a number of formulas. I mean, a number of companies which have the formula. As I told you, everything we have 3-chamber bag to be broadly classifying them. We have 3-chamber bag, 2-chamber bag. Okay, in 3-chamber bag there will be amino acids, which in one chamber, fat in another chamber, glucose in another chamber, or dextrose in another chamber. So all three will be mixed together. And when the bag is going to the patient, it will look milky white because fat is there. Okay. So in this we have, and then we have a 2-chamber bag. In 2-chamber bag, lipids will not be there. That is, fat will not be there. Only the amino acid and dextrose will be there. This bag, when mixed together and hung, it will look very clear like a water. So this is it. So there are, based on the lipid composition. Okay. It could, dextrose and amino acid cannot vary because just protein and sugar. Okay, only the lipid combination can vary. Lipid can be MCT, LCT combination, that is medium chain triglyceride and long chain triglyceride combination. It could be a olive oil based lipid which is available, or it can be a 5 oil combination where MCT, LCT, fish oil, olive oil have been used for the and soybean oil. So these 5 oils are mixed together. It is called a SMOF carb event. So which means 5 lipids are mixed together. So this is the recent trend which you are using, all the 5 lipids together. When it is just MCT and LCT, it increases the inflammation of the patient. So generally we don't give them. Now only in gynec cases they're using that. For this olive oil based can be used for critically ill patients or patients who have severe inflammation in cancer cases. They use olive oil based. Fish oil based are patients who are used for severe respiratory distress. For such patients, we can use fish oil. All in these 5 oils together can be used for all categories safely, even in pediatrics. Yes, hope I've answered your question.
Yes, ma'am. Thank you, ma'am. Ma'am, will there be gastric distension after right tube feeding or after enteral feeding?
Gastric distension after?
Enteral feeding.
After? It's not clear.
Enteral feeding.
Enteral feeding.
Enteral feeding, after enteral feeding.
Enteral feeding?
Yeah.
No, definitely not. That's why I told you, no. Enteral nutrition will not cause gastric distension unless the patient's mobility, in case there's some disease condition that's different. Okay, there are cases where abdominal distension can happen because the feed is not getting digested properly, or there is, as I told you, there is ileus, there's necrosis, there's no blood supply to the stomach, pancreatitis, all that distension may be there. But enteral feeding per se is safe because, as I told you, it's just a tube. Instead of your esophagus, you're using an external tube to fill the your tank like your stomach. So it doesn't generally happen. In case distension do happen, in cases which I listed out, we go to peptide formulas, okay, where only absorption is required, no digestion is required. Even still, the patient has got intolerance in the form of diarrhea, vomiting, or distension, then we go to parental nutrition.
Thank you, ma'am.